Patients who are on antipsychotics can present to the psychiatric emergency departments with a range of symptoms that can include basically the extrapyramidal side effects, that is the ESPs, and sometimes they also need the rapid tranquilization techniques, or even the resuscitations can finally be needed for such individuals. So over here we are discussing the withdrawal symptoms of the antipsychotics along with the on medication side effects of such antipsychotic medications. We'll be basically assessing the individual, first of all, giving him or her the first line treatment modalities just to make him stable, and then the long-term therapy of such individuals. So that will basically include the management of such individuals, and then we'll move on to the non-medical interventions. That will basically include giving the patient insight towards the side effects of such antipsychotics. Then the rapid tranquilization technique will be discussed in detail over here. That is needed for some of the individuals out there who have symptoms regarding the antipsychotic medications. The management basically includes the pharmacological management. Obviously, we'll be dealing with a lot of drugs that are related to such kind of a management. Then the non-pharmacological approach, that will basically comprise of the counseling sessions and the cognitive behavioral therapies. And then the psychiatric intensive care units, that is basically the PICUs, also known as the psychiatric intensive care units. And they're basically designed for such psychiatric patients who have the side effects for the antipsychotics, as well as they are also the emergency departments for the psychiatric department. The non-medical interventions, they basically include the first line element of the non-pharmacological approach. The communication should be very clear. Now, it's very important to develop that patient-doctor rapport when you're dealing with a psychiatric patient. A patient who is suffering from a psychiatric illness, that rapport again is very important. The communication should be clear. It should be consistent, it should be firm, and it should be non-confrontational. So there should be the open-ended questions that are put forth to the patient, so he or she can give you a clear history of his or her problem. When speaking to the patient, one person should talk. So it should not be a team that should be talking to that individual. It should be a personal trait. The communication should have a personal trait, and only one person should be dealing with that particular psychiatric illness patient. Then adding a slower rate and a tone to add clarity. So all of these characteristics should be a part and parcel of the counseling sessions that one should have with such a psychiatric patient. The lighting should be bright so that not to misinterpret the shadows, because these patients who are suffering from the psychiatric ailments, they are sometimes having the auditory, the visual hallucinations even. So the shadows should not be there, they should be limited. So the lighting should be bright, and it should not basically misinterpret the shadowing phenomena in the counseling room. So these are the points that should be remembered by the clinician as well. The environmental conditions that should be kept in mind, that is basically remove the items conferring risk for the patient. Because of the acute behavioral disturbances, the person can get violent. So there should be less risk for the patient and as well as the doctor in the counseling session rooms. Then it should include the cables to trip over them, items that can be used as improvised weapons. So we should look in the environment of the counseling session rooms. It should be a clear-cut environment, not having any weapons, not having any risk factors for the patient as well as the individual who is taking the history. The amount of stimulation should be minimized involving the lighting phenomena, as we've already discussed. Then the time out away from the situation provoking behavior. So the questioning should be such that the behavior should not be provoked. The person should not go into an agitated state, into an irritable state. So all of these phenomena have to be kept in mind. Then when we talk about the rapid tranquilization technique, obviously we have these range of drugs over there. It's basically ranging from the intramuscular monotherapy, in which a single drug is used. Then we have the intramuscular combinations that are used. And then finally, we have the intravenous monotherapies. When we talk about the intramuscular monotherapies, the drugs included are the lorazepam, promethazine, droperidol, and olanzapine. Talking about the IM combinations, it is usually the promethazine plus haloperidol, and then we can also combine lorazepam plus the haloperidol. So this is the combinations which is usually given intramuscularly. Then when we talk about the intravenous therapy, the drugs are usually of the monotherapy type, and it basically includes the lorazepam, midazolam, and droperidol. So these are the drugs that are used as a monotherapy when we are dealing with an IV or intravenous monotherapy. Talking about the antipsychotics, it is sometimes the first line treatment in a lot of psychiatric ailments, for example, psychosis, or even the bipolar affective disorders in which the mania is quite prevalent in such individuals. Olanzapine decreases the side effects in a lot of individuals like dystonia. And in urgent intervention, if it is needed, we usually have antipsychotics at our hand. It requires the IM administration in a lot of individuals. The routes of administrations, it is sometimes given orally. The patients may secrete the tablets, and ESPs are very common when we administer these drugs intramuscularly. So this is a very common side effect, that is the extrapyramidal side effects, in which there is basically an acute dystonia which is seen in such individuals. Then we can have intravenous administration, and sometimes if resuscitation facilities are available, these antipsychotics are administered intravenously in a lot of individuals. Talking about the antipsychotics, moreover, it's basically haloperidol is sometimes the drug of choice in a lot of individuals because of the safe low propensity. And for sedation and hypotension, this drug is sometimes the drug of choice. Extrapyramidal side effects are very common with the haloperidol. Its effects last from 6 to 18 hours. Chlorpromazine is marked hypotensive side effects are seen in such individuals, as well as olanzapine, aripiprazole are alternatives to the haloperidol. So all of these groups of antipsychotic drugs should be kept in mind along with their side effects and along with their advantages. Now, zooclopenthisol acetate is one of the antipsychotics. For known diagnosis, it is given sometimes. Its effects last for almost 72 hours. It is not used in the neuroleptic naive patients. It has a long duration of action mask effects, and the depot antipsychotics are not used for the rapid tranquilization in such a toxicosis of zooclopentithol acetate. So all of these characteristics for the separate drugs have to be kept in mind whenever we have patients with the withdrawal symptoms of the antipsychotics, or they are having the toxicity symptoms of a particular antipsychotic. The prescription has to be taken first of all, and we should know what are the drugs that the patient is on. The conventional antipsychotics, when they are compared to the atypical antipsychotics, basically the conventional antipsychotics, they include the chlorpromazine, flufenazine, haloperidol or loxapine, molandron or perfenazine, pymozide, fluorchloroprazine, thiothiazine, thyrodazine, and trifluparazine. So this is basically the group of the antipsychotics which is regarded as the conventional antipsychotics, and obviously the side effects that are related to these conventional antipsychotics are quite much more than the atypical antipsychotics that basically include the aripiprazole, clozapine, olanzapine, paliperidol, quetiapine, risperidone, and ziprasidone. So this is the group of the antipsychotics which is basically included in the atypical antipsychotics, having somewhat lesser side effects than the conventional antipsychotics. Now, sometimes in a lot of conditions, benzodiazepines are given as the drug of choice. The patients already on a high dose of antipsychotics are sometimes given the benzodiazepines. Or if the patient has a previous history of adverse effects with the antipsychotics, then benzodiazepines are sometimes the drug of choice. If the patient is antipsychotic naive or has a history of epilepsy. So this is basically the conditions in which benzodiazepines are given. Now, the treatment plan, when we consider in such individuals who are having side effects with the antipsychotics, the drugs of choice are usually lorazepam because of the short half-life, the high potency at the receptor, and sometimes it is given orally or IM 1 to 2 milligrams. Then we can also consider the combination therapy combining an antipsychotic with benzodiazepine. But the side effects usually include the excessive sedation of the individual. The vitals and clinical status monitoring is to be regarded in such individuals who are taking antipsychotics along with the benzodiazepines. These dosages usually are the 5 to 10 milligrams of haloperidol, 1 to 2 milligrams of lorazepam, oral or muscular, and then newer generation drugs, for example, olanzapine, is sometimes given alone. So these are the drugs, or these are the treatment plans for individuals who are on antipsychotics and they are having side effects that are related to such antipsychotics or benzodiazepines. Sometimes the acute tranquilization technique is administered in a lot of individuals, and there are a lot of risk factors that are related to such acute tranquilization. The risks involved in such a treatment include the bradycardia or tachycardia, then hypotension, prolonged QT interval, arrhythmias or respiratory depression. Along with that, the extrapyramidal side effects, also abbreviated as EPSEs. It's not basically ESPEs, and the acute dystonias. So these are the range of side effects that is sometimes seen in patients who are put on the acute tranquilization. Along with that, local pain at the injection sites is sometimes observed in a lot of individuals. Along with that, we have seizures or the neuroleptic malignant syndrome, abbreviated as NMS. So in this section, basically, we regarded with the side effects or the withdrawal symptoms of the antipsychotics and how can we have the treatment modalities inculcated in such individuals. So that is the end of this section. Thank you for watching sqadia.com.